Today we're going to have a presentation from Dr. Jason Hassenstab. Dr. Hassenstab, sorry, pulling up your bio again. There we go, is an associate professor of neurology and of psychological and brain sciences, and is the director of the Cognitive Technology Research Lab at Washington University in St. Louis. He also leads the cognition course for the dominantly inherited Alzheimer's Network Trials Unit and the DIAN Observational Study, and the Charles F. and Joanne Knight Alzheimer's Disease Research Center. The CTR Lab's focus is on using technology to improve cognitive assessments in Alzheimer's disease and other disorders. Dr. Hassenstab's most recent projects include development of the Ambulatory Research and Cognition smartphone application for the DIAN observational study, the DIAN 2 phase 3 clinical trials, and the Healthy Aging and Senile Dementia Program project grant at the Knight ADRC. Prior to pursuing academics, Dr. Hassenstab toured internationally as a professional jazz saxophonist. So we are very, very happy to have him here presenting for us today. Dr. Hassenstab, feel free to take it away.
Okay, thanks, Brittany, for the nice introduction. In case you're wondering, yes, I am sitting in a hammock. I'm actually on vacation this week with my family, and this is the only quiet place I could find, so you'll have to accept my comfort. All right, I need to minimize this because it's in the way. Hold on a second. Okay. These are my disclosures. Nothing is really relevant for what I'm going to talk about today. So just a quick overview. I'm going to cover transitioning the Knight Alzheimer's Research Center to remote cognitive assessments. I'll talk a little bit about a smartphone application that we developed about 3 years ago now, that luckily for us came into real use during the pandemic. I'll talk about some web-based options and cover some new things that we've been working on in my laboratory. And then if I have time, which I probably won't, I've got a lot of slides, we'll talk about adherence for remote studies, which I think is one of the most important issues that we face. So here's what we did pre-COVID-19. So the ADRC has been around seeing participants since the early 80s. And we have a pretty honed methodology for doing cognitive assessments, which is nothing remarkable. But in the past 10 years, we've even made it more efficient. And it's really easy for people. We make a phone call and schedule the visit. The participants park right outside of our building, walk inside. They complete their cognitive assessment, their clinical assessment, and then they leave. That's it. We score the data, we do the QC, the data entry, just as we have always done for 30, 40 years now at the center. Since COVID came around, however, we've had to really rethink what we've done and do it in a hurry to keep our studies running and to keep our participants engaged. So when we started converting to remote visits, like many of us at the hospital here at the medical school, we had to consider a lot of things. The first question for us, which was which technology should we use? Should it be over the phone, video conference, web, smartphones? We also have to consider our populations. For us, it's very relevant that we need to consider the fact that we have older adults, and a large proportion of older adults, although this is changing every day, are not as familiar with technology. There's a lot of technological phobias in older adults. But I'll show you some data that suggests that it's a total myth that older adults cannot use technology. And the pandemic has only increased their engagement with technology by necessity. Technology access is a real issue for us. Participants may not have equal access to technology. Then there's, of course, data quality. The data that we collect in person, over the phone, via Zoom, via the web, or the smartphone, are they equivalent? And then finally, how can we equate these modalities so that our data can be used seamlessly? So when participants when other investigators request the data from the ADRC, as they often do, we want to give them a seamless data set. Maybe we have a new variable that says how the data was collected, whether it was remote or in person, by phone, Zoom, or whatever, but we want to make sure to do as much as we can to protect the fidelity of those assessments. So this is where we were starting from. So the pandemic hit us, we shut down in March, and we took a look at our current cognitive battery. We have a pretty lengthy battery. It's about an hour and a half. And it's also very, very comprehensive. As you can see, the types of cognitive domains that we assess are pretty broad. Then we looked at the list of tests and we thought, well, how could we start doing this quickly and easily? The first option is of course by phone. I would say probably 100% of our participants have a way to be reached by phone because that's how we do everything. So, but when we took a look at what we could do by phone, we started getting pretty reduced pretty quickly. Some things worked in red here pretty well, short versions of mental status, some memory tests, some working memory and semantic memory tests, but look, we were losing entire domains of cognition. We couldn't measure processing speed. Visual spatial functioning was totally gone. Executive functions were out of the question with our current methods. And this is what we were left with: a short version of mental status, some memory tests, working in semantic memory, which is not bad. You can actually get a pretty comprehensive assessment if you're interested in Alzheimer's disease using these methods. But if you wanted to do something more or other things, we were going to have to obviously increase the technology that we're going to use. So then we started thinking, well, there's some cons with telephone assessments, right? As I just said, you don't have as many tests that you can give. There's also things like timing. If response time is an outcome, it's really difficult to do that over the phone. Hearing problems in older adults may be exacerbated, and so the quality of the audio is very important. Like if I'm calling a participant on a mobile phone and they're using a mobile phone, it drops out, or they just can't hear you at all. Then for our psychometrists, the people actually collecting the data, they're at home. And the university is not providing phones for us to do these remote assessments at this point, at least. So we had these questions of, do we use our personal mobile phones to call participants? Do we, block the number with the whatever technology you can use? So, but then the participants, if it comes from an identified source, they wouldn't answer. So then we started looking at different services like Doximity, iPlum. There's dozens of these out there, but they all cost additional funds, which we didn't budget for. We ended up using iPlum because it enabled internet calling, which improves the quality, and you can control the number that shows up on the caller ID and the name that shows up on the caller ID. So we could choose something that the participants might recognize and be familiar with. And this is a real issue for people when you just get called out of nowhere and you don't recognize the number. I know for myself, I don't ever answer it, and increasingly a lot of older adults don't. Then we started thinking about video conference assessment technology. And of course, we're on one right now. The preferred one we like is Zoom, but those have some limitations as well. The tech can be really challenging to set up. Screen sizes vary for participants. They might want to use tablets. Tablets are very popular with older adults, it turns out. They may try to use their smartphone for this. We also have to ensure that the participants, sorry, someone is starting a car out here and it's not going well. Anyway, the type of screen size really varies. So we need to make sure that they can see everything that we're trying to present to them. And then the other thing with video conferencing, as we may experience here, is that the internet connection quality is obviously very important. Things happen on Zoom or video conference. They drop out, people freeze. Screen sharing is not always a viable option for people either. Oh, good, they got it started. Okay. Then there's hearing problems are still a concern over video conference, although I think it's to a lesser degree because they can see your face. And many older adults read lips and they don't even know that they're reading lips, but they are doing it. And I think that they can also adjust the volume a little bit easier, put on headphones. Anyway, and we've come up with a protocol to help older adults adapt to this. Then lastly, although this hasn't been as much of a concern, we were thinking about privacy. We're viewing participants' homes, they're viewing our homes, and of course the university has provided us with HIPAA certified Zoom. They provided us with backgrounds to use, but we're also viewing participants' private homes, and they may not like that so much. But we haven't really run into this too much, and it hasn't been viewed as an issue. Then there's web-based assessments. So we can program a lot of the things that we do onto the web, but of course the tech can be challenging. There's the screen size concerns, just like with video conferencing. People will try to do web-based assessments on their smartphones, which generally doesn't work. The type of assessments you do are also can be very browser dependent, or the software that you use can be browser dependent. Internet Explorer is very frustrating technology for these types of assessments, but the other ones tend to work a little bit better. Then of course there's security issues. The requirements of the types of assessment that you want to use are another real concern. I mean, if you're going to use audio over the web, that can be a tremendous issue. I mean, especially with older adults, some of them have no idea how to control the volume on their devices, although, as I said before, they can be shown how to do this. Then there's response time accuracy is the other big issue. So if you're giving something that requires a very precise response time and it's going over the internet via a browser of uncertain age on a computer of uncertain age, it can be variable. And what I've found after doing this for a couple of years is that shorter and simpler measures are almost always better. Try to reduce the number of modalities that you're using with these web-based assessments, and you'll end up with better data. And I'll show you some data here in a minute. So here's what we came up with for the Knight Alzheimer's Disease Research Center approach. We started off, if you go from left to right on your screen, with what could we do at a base minimum, and then essentially everything as you move to the right adds on to that assessment. And you can see all the way on the right in red are the things that we just couldn't do, which really are just two of these tests, because we figured out how to do web-based versions of them in the interim. We can't really do a figure drawing task, even on video conferencing. It's just too difficult to control the environment, and it's also really difficult to build these tasks into a web-based version. And then the other one may surprise you if you know this test, letter number sequencing, because it's entirely done using your voice. You know, there's no stimuli, but there's something about letters and numbers over the phone that older adults and normal adults just can't distinguish. So if you have a name like Hal, that may seem H-A-L, like very easy to hear, but if I pronounce a letter D or T or C, they kind of blend together and you can't repeat them. So you have to make sure the participants hear them, and it just doesn't work. We tried for about 150 assessments doing letter number sequencing, and the data is just terrible because we have no idea if they can actually discern the different letters. When you're in person, sitting across from them, you can kind of gauge how well they're hearing you or not, and it's much easier when they're looking at your face and can read your lips. So that one just didn't work. But in general, we have a pretty comprehensive assessment that covers a lot of the domains that we had that I showed you before, plus the smartphone test, which I'll go into detail about in a minute. So just to overview, here's where we started with our workflow. One phone call, participant arrives, takes their tests and goes home, and it's done. And here's where we ended up as a result of these different modalities and trying to figure out what works with older adults and what doesn't. We now have a pre-visit that is quite involved. Our psychometrists are calling the participants to schedule them because we're trying to schedule them and also knock out some readiness for technology type questions. So the first visit is technology readiness. We assess their tech options. You know, do they have a computer that works? What type of computer? Have they used Zoom before or not? Do they feel comfortable visiting websites? Do they have a smartphone for the smartphone-based testing? How old is that smartphone? We complete a test run of technology during this first pre-visit call. So if they don't know how to use Zoom, we found some internet resources, which I'm very willing to share with anyone on the call here, that are really easy to use for older adults that explain it very clearly. We run them through if they need help visiting websites. We show them how to do that, make sure that their audio works on those websites because they need it for some of our tests. And so that entire first visit is just involved in assessing their readiness for technology and testing it out. This involves two people. We have the ARC study, which is the smartphone study, has a coordinator, plus the psychometrist for the ADRC. So those two people are on the call, plus the participant. And if the participant is impaired, we also have to get the collateral source on the phone at the same time to help out with all of this. So you can see we went from a pretty simple scenario to a pretty complex one really quickly, and it even gets more complex. The time requirements for this are pretty significant. Scheduling often requires multiple calls. As I said, they're getting a phone call from an unusual number, and also, just normal trying to reach people. It just has to cycle around a bit. If the collateral source is required and has to be on the phone at the same time as the patient, that adds more complexity. If there's no tech involved, however, the scheduling call is like 10 minutes. But if we need tech intervention is needed, like setting up Zoom, helping out with a smartphone, it can take as long as 45 minutes. So our original hour-and-a-half assessment, basically 50% of that has just now been spent getting them ready for the visit. On average, we find it takes about 2 to 4 phone calls just to set up this visit. And then once reached, it's 10 to 45 minutes, not including like missed calls. So that's part one. Then back end here to the pre-assessment visit, we have the psychometrist sends an email to the participants with a Zoom link if they're doing the Zoom call, also with information on the web testing, including a link to access the web portal. The smartphone coordinator sends separate email with consent, further instructions, and then a lot of our participants don't have a smartphone or have a very old one, so we have to ship a smartphone out to them. So all of this is new that we never have done before because we could handle all of this in person when they came to the clinic. Then the actual visit begins. The patient and the psychometrist log on to Zoom. The psychometrist stays on the phone or Zoom while they complete the web testing, and that's in case they have questions or difficulty accessing things. So they can be right there. They usually screen share with them, and they can address issues right away. Then the ARC coordinator joins the call to initiate the smartphone assessment. So time requirements. Phone only is once the visit is scheduled, it's another 30 minutes to complete the testing. If they do Zoom, it's about an hour. If they do Zoom plus the web-based testing, 75 minutes. And if they add smartphone on it, really very much depends on how familiar they are with smartphones. We can get up to like 2 hours. So our totals here, we went from 2 to 4 phone calls. We went from basically, 1 or 2 scheduling calls to the actual visit to now 2 to 4 phone calls just to schedule up the pre-visit, then multiple calls and 30 to 120 minutes to do the actual assessment. So it's a big change for us. So how is it going? Well, we shut down like the whole university, I think mid-March. I can't remember if it was March 18th. That sounds right to me. But we started up with this remote visit option on April 30th after a ton of work in the interim to get this ready, including programming tasks on the web de novo that have never been done before. We have completed about 254 assessments, about 90 of those, so about a third have just been done by phone. And the reasons for audio only are below, and by far the most common reasons was that they didn't have computer internet, or they had so much difficulty setting it up that we could sense that they were feeling really burdened and just said, okay, that's fine, we're just going to go by phone. About 60% have been done over Zoom, just a handful that have been done on FaceTime because people preferred it that way. And of 254 of those assessments, about 70% were also able to complete web-based testing. So for older adults, average age is probably about 82 here in the sample. This is pretty darn good. It's not 82, I think it's more like 75, sorry. But still, definitely an older group, and we've done pretty well. And I'm really proud of my team for being able to accomplish all of this. So here's some impressions that I thought were worth sharing from the psychometrists and other people on the team. Generally, people have accepted this. They're very patient. They understand it's a pandemic. It's an unusual situation. But the biggest obstacles, and there's a theme here of hearing and lack of experience with technology. Some people, once they learn Zoom, they seem to really like it. So we vastly prefer it because of the hearing issues and the personal connection that we make. That personal engagement with people is very, very important for all of our studies. So some participants mentioned that they prefer to do the remote testing, actually, which was a big surprise. While others say that they really miss the seeing others, because many of our participants have been in the study for in some cases more than 20 years, and they really look forward to seeing the staff and the faculty at the center. but overall, I think it's going pretty well. So I'm gonna stop there just to take any questions if there are any. I can't see the chat function, but if anyone has any questions,
So looks like Dr. Lang wanted to know if you think privacy issues related to viewing homes varies with population. For example, parents' concerns when running pediatric studies.
I can't speak to pediatric studies, but I can tell you from our older adults, we really thought there would be more of a concern, as I said, and there just wasn't. I don't know about the pediatric population. If anyone else is on the line that has experience with this, please jump in, but I just don't know about that.
So this is Catherine Lang who asked the question. I'm asking, we do some studies with wearable sensors, and our older adults and middle-aged adults with stroke have no problem with us coming to visit their house or dropping off sensors or picking up sensors from their house. But our pediatric patients, which is a psychiatric condition, the parents are very uninterested and will not let us come to their houses. So I didn't know if we had anyone else had any experience with Zoom or other things with the pediatric groups.
No, don't know. Okay. So I'm going to transition now to talking about smartphones, which, as I mentioned before, we didn't plan this as a result of the pandemic. This is ongoing work that my lab's been doing for about 3 years now, but it's turned out to be very fortuitous for us, obviously, which I hate to use the word fortuitous because of a pandemic, but you understand what I mean. So I always like to show this slide to give some rationale for why we adopted this methodology. I'm a neuropsychologist. I give cognitive tests, for the past like 25 years or so. And if this is what we want to happen, right? So let's say we have a disease that has an onset, and we were able to detect a preclinical phase of the disease using cognitive tests very reliably. And from year to year, we got very consistent performance where if someone scored, a 50 on a test, they would probably score a couple points within that the next year. And if they were in the disease group, which is in black here, they would show a pretty reliable decline where we would be able to predict their next score pretty reliably. And this is actually a bit of a fantasy because this is actually what we end up with. These are gold standard neuropsychological tests that people have been giving for decades. And these are memory measures, which I think are the most variable tests of all. And you can see a couple of interesting things here. I mean, we see patterns in the data. So these, the people in blue here would be normal, and the people in black have like amyloid in their brain, but they're cognitively normal. But the problem is that people vary tremendously on these tests. And there's no reason why people who are cognitively normal and have no amyloid in their brain should vary by 1.5 standard deviations between assessments. That's kind of a failure, in my opinion. And it's not that we can't get anything useful out of these tests, it's just that it should be better. So we looked at the test-retest reliability in the literature and found, people were reporting test-retest reliability of, 0.7, 0.8, even 0.9 for some tests. But when we looked into actual studies, we didn't find the same thing at all. We actually found a much different picture where reliabilities were far lower. And then when we looked in the night ADRC, we found even lower reliabilities, and especially on memory tests, which are in Alzheimer's disease extremely important for us. So look at the far right column. Again, these are normal older adults that have no symptoms. They have no amyloid in their brain. They're living healthy lives, average age of about 72 to 75 years old. So if you double that correlation, square that correlation, which we all learned in Stats 101, you can see that we're explaining about 20–30% of the variance from visit to visit. That's pretty terrible. So what's going on? Like, why is this happening? Some tests are better than others, but on the average, this is pretty poor. Well, I think traditional cognitive assessments have a lot of limitations. The assessments are really far removed from reality. They don't really represent how we use cognition in daily life. And to be fair, these tests weren't designed for that. They were designed to localize lesions or detect gross disturbances in cognition. And the other thing is that the environments in which we take those tests, like you remember that picture I showed you of the woman sitting across from the man, one person has a clipboard, is very artificial, right? They're fundamentally dissimilar from the way that we use cognition. There's that feeling of being tested by another person. Then there's white coat testing effects, which are very, very real. You come to a center, you sit down from a person you've never met before. They may have a white coat on and then the clipboard, and you might be really nervous and do pretty poorly. Then there's daily stressors. Many of our participants travel long distances to come to our centers for clinical examinations or for research participation, and they might be tired, or maybe they came and stayed with their sister in town and got a lot of sleep for their next visit, and they're feeling pretty good, right? So these things all result in dramatic fluctuations that can affect cognitive performance. The other thing that we do with traditional cognitive assessments is that we concentrate everything into one. So we say, okay, I've got this person who's got these cognitive difficulties, or I think suspected cognitive difficulties, and I'm going to give them the most comprehensive and difficult cognitive assessment ever, and I'm going to concentrate it all into one 2-hour period, but as I said, you end up with fluctuations, and I think this really represents this pretty well. So this is a figure that I borrowed from a colleague of mine, Marty Slawinski at Penn State University. If we think of cognitive function having fluctuations, and fluctuations that could occur on an hourly level or daily level or even minute by minute, where you're measuring them in there can vastly influence your results. And I think this is phony data, but it represents the construct here pretty well. So at baseline, you might catch someone on a bad day, and at follow-up, you might catch someone on a good day and actually miss their true change if you would assess them repeatedly. And all this has drastic reductions in the upshot of all this is that high variability leads to drastic reductions in statistical power. And so that's the basis behind the ARC smartphone application, is that we administer very brief cognitive tests multiple times over a week. We test people for about 3 minutes, about 4 times a day for a week. And the idea behind this is really, really simple. We test often and everywhere in the context in which we use cognition normally. We keep everything really, really short, so it's not a big interruption in their life, and they don't go into test taking mode necessarily. And then we combine the results so that we're embracing that fluctuation over time and actually looking at either the median or the mean of the performance across time. So this is what our application looks like. Participants set a wake and a sleep time for 1 week of testing. So essentially they say I wake up at 7 and I go to sleep at 10. And then during those hours at quasi-random intervals, they get a notification, just like a text message or any other notification on your phone. They tap on that and they begin the tests. And these are what the tests look like. This is the GRIDS test. And this is based off of a classic cognitive neuropsychology paradigm. The idea here is that they see 3 common objects, then they do a distraction task. In this case, they're asked to tap the Fs. Then they see a blank grid and they're asked to place the items. And then they place where they think the items went. This is a very, very brief test. It takes about 35 seconds on average for people to complete. They do 2 rounds of object location identification. The next test is called Symbols. It's a processing speed test. And this is very similar to one of the Wechsler intelligence scale items called symbol search. And the idea here is that participants see they see 2 pairs of symbols on the bottom and 3 pairs across the top. And they very, very quickly have to choose which pair matches one of the 3 on the top. So for example, this one matches this one. They see 12 pairs of this and they're asked to respond as quickly as they can. And this one is really fast. And also, for some reason, the participants absolutely love this test. It's by far their favorite. Some people can complete this in 12 seconds. Some people can take about 40, 45 seconds, depending on how impaired and their sort of personal decision-making style. Then a new test that we spent a lot of time developing on is called Prices. And this is an associate memory paradigm. And the idea behind this is that we take an item and a price and we put them together. And then we ask them later to choose which was the price of the item. So for example, they may say bananas are this price, dental floss is this price, and then later they have to just make a 2-choice, forced choice recognition which was the price. And we've piloted this test on thousands of individuals online in order to fine tune the parameters of the paradigm to get it right where we wanted in terms of sensitivity, floor and ceiling effects. And we ended up with 10 price item pairs that we present for 3 seconds each during the study phase. And then of course they have as much time as they need during the recall phase. So how do the visits work? Well, what we do is we do 7 days of testing 2 times per year. And so, for example, this is a hypothetical situation. A participant says they're available between 7 a.m. and 10 p.m. Tests are randomly distributed throughout the week and throughout the day. Once they get a notification, they have 2 hours to respond. And that's very, very important because we don't want our participants to feel like they have to pull over the side of the road and start taking the test. And many of our participants still have jobs and other priorities, and so they can't just drop everything and start taking a test. And if this seems like a lot of testing, it is. But keep in mind that each one of these interactions is less than 3 minutes. By the time that they tap on that notification and complete their testing, it's usually about 2 minutes and 40 seconds on average. So it's very, very fast, which by the way is about as much time people take to pick up their phone and check social media or an email. In a typical total interaction time is very, very similar. And we designed it that way on purpose. So I'm going to show you some results of this now from the Healthy Aging and Senile Dementia study, which is an ongoing study that's been, I think, originally funded in around 1984 or so at the Knight Alzheimer's Disease Center, and it's probably on its, I don't even know which renewal it's on. So it's been around for a really long time. I'm going to show you some very early data, just about 50 participants that have completed, and I put this data together back in July. So so far we've approached 100. In July we had approached about 111 people. We had 21 refusals. Some people were saying, I don't want to do this now, I'll wait till it's in clinic. As of today, I think we're about at 150 people that have enrolled. And just a couple of things to look at here. One thing is here, the age range. We have 2 91-year-olds and 1 88-year-old, and they have never owned or operated a smartphone before this. And we were able to teach them how to do it, and they've done it successfully. And it's pretty remarkable. It's pretty cool to see. And they absolutely love it. They call us and say, you know, I learned how to text my grandchildren, and I did FaceTime with my daughter the other day, and they couldn't believe it. It's pretty cool. There's some things to consider here, though. We have a very high SES population, as you can see right below. Education is pretty much at a postgraduate level on average in our study, and it's predominantly a white sample. But other than that, we have pretty good representation, and we do have a few people who are actually cognitively impaired. And by now we have many more that have cognitive impairment, and almost all of them are able to do this. So one thing that we really care about is reliability, as I mentioned at the beginning. And the type of reliability that I'm going to show you is called between-person reliability. And this is the proportion of total variance that's attributable to differences between persons as opposed to other sources of variance. And there's a couple critical things here to look at. And I know nobody likes looking at equations, but if I could point your attention to this little n here. So if we did this enough times, like if we gave a really unreliable test enough times, just by virtue of the way that this is mathematically constructed, that reliability will approach 1. But the goal here is to not give tests really long and repeatedly over and over and over again. We want to give the test as few times as possible so that we can maximize this reliability for each person, and therefore increase the power to detect either decline, or if it were a clinical trial, the treatment effect. Our goal that which we set was pretty arbitrary, was to achieve a reliability of 0.9 or better for each measure. So here's how we're doing so far. So this is about 50 people, 49 people that have been in the study. And if we look at this reliability, we can see that it asymptotes pretty quickly for the symbols test, which is in blue. That's the shape matching one. And then for the prices test, memory tests are tough. It doesn't actually reach our goal, and even after people have completed about 22 sessions, and we've made some changes to the test that I think are going to result in even better reliability. But overall, we're very, very pleased with this, to see that such high reliability after administering the symbols test, even just a handful of times. The GRIDS test takes a little bit longer, but it gets there. And the prices test, I think, will be there soon with the next iteration that we pushed out last August. So adherence is a big problem for remote studies, and it's something I can talk about at length, and this is the subject of my next R01, as a matter of fact, is studying different methods for increasing adherence. So we've had pretty good. So on average, participants are completing about 20 out of the 28 tests, you know, plus or minus a few. The median adherence is about 75%. And as you can see from the histogram, there's most people are very adherent, and then there's some people that are sort of in between. And we haven't really looked at this data yet to see what types of factors lead to better adherence. So I know that's an obvious question, is if they have more cognitive impairment, are they less adherent, or if they're less familiar with technology, are they less adherent? In fact, it's the latter point. It's actually the opposite. The more adherent they are, usually it means that the less they've experience they have with technology, probably because it's new and it's a shiny new thing for them to do, and they want to engage in it. So how well do these tests compare to in-clinic tests that we've been giving for decades at the Alzheimer's Center? Well, a couple of things to notice here. The first is the correlation with age on the speed test, which we expected to be very high, and it is. When you're looking at a cognitively normal population, or a population that has some Alzheimer's disease pathology in it, that really tends to overwhelm any sort of age-related correlations. Now, another thing to keep in mind here is that on our tests, they're error scores, so higher scores are worse. So the directions of these correlations are important, and they're all in the right direction. And you might be thinking, like, well, these aren't super impressive, you know, 0.4, 0.3. But remember, the in-clinic tests are not that reliable themselves. So we can't really compare a super reliable test with an unreliable test and expect to get a really high correlation. But I think the important thing here is that they're all in the right direction. And also the ARC measures aren't very correlated with each other, which I think says that they're measuring something unique. And on a global cognitive scale, if we combine all the ARC measures into a composite and compare it with like something global like a MoCA, we're getting an excellent correlation, which we would expect. So that's one type of validity. And another one would be, how well do these measures correlate with Alzheimer's disease biomarkers? So this is a very small sample. It's just 34 participants at this point. And in here, I think there are just 2 people who had active symptoms. But so far, the composite of the ARC smartphone measures is showing a very strong correlation with PET amyloid. We obviously need a lot more data. And if we compare this to a composite of the in-clinic tests, which we call our preclinical Alzheimer's disease cognitive composite, the correlation is slightly better in ARC, but it's too early to say whether one is better or the other. But I don't think the real strength of ARC is going to be in a point estimate. I think you'll get a much more reliable idea of people's cognition on a point estimate, but I think the real strength will be when we have enough data to look at repeated measures. So after these people have been in the study for 2 and 3 years, to look at their rate of change estimates, I believe on ARC, I hope on ARC will be very stable, and we won't see these wild fluctuations that I showed you at the beginning. So do people like ARC? So we updated this just a few weeks ago because I believe it's very, very important to look at this user experience data continuously. So this is actually from 109 people, so more data than the previous slide showed you. And I think overall this is pretty good. One thing we're really concerned about is asking people to do this 4 times a day. Is that too much for you? And in general, people are like neutral to no, it's not too bad. The biggest spread we saw was whether or not it was difficult to take the test within a 2-hour window. So once you get a notification, you have 2 hours, right? And people really had a divergence of opinion on this. People didn't necessarily prefer this to paper tests, but sort of. No concerns about privacy except for 1 or 2 individuals out of 109. Like, it was amazing. I was really shocked by that. They didn't find installation hard, but of course we have a really excellent coordinator who helps them do this, even over the phone. They didn't have issues with instructions. We ask a lot of questions about sleep because there's a big connection between sleep and Alzheimer's disease. They didn't find that to be too difficult, and providing scores as an incentive to complete more tests was also not a big incentive. So overall, I'd say Ronaldo says not bad, not bad, not great, but not bad. We're constantly making improvements to the app. We've done a lot of research on user experience, and we are going to make some major changes to the app within the next year that I think will make it a lot more usable for all participants. So I'm going to stop there and see if anyone has any questions about the smartphone approaches that we've been doing. I see something popped up in the chat. Oh, it's Ganesh. Hey, Ganesh.
Hey, Jason.
Okay, have you examined how many of the participants in the sample of collected data are hearing impaired versus uncorrected? In the remote testing, that's definitely something that we're interested in doing. It's obviously doesn't apply to the smartphone testing, but for the remote testing that we do in the clinic at the ADRC, it's definitely something of interest. I don't know offhand if we collect, are you hearing impaired, do you use a hearing aid or not, but it sounds like we probably should collect that. Anyone else have a question about the smartphone data or anything else? Okay, I'm going to move on to some remote assessments that we're working on. I was going to talk about some older stuff that we're doing, but then now that I definitely don't have enough time, I'm just going to talk about some of the new things that we've been working on. And I'm really, really excited about these, so I hope you all like them. We're really interested in what I would call within subject paradigms. We've been working with two colleagues of mine from Australia, Yin-Ying Lim and Paul Maruff, on this test called the Online Repeated Cognitive Assessment. And I really like this task for a number of reasons, which I'll elaborate on. In this test, it's based on approaches used in statistical learning, which is like if you see something enough, you start to make associations between the items, which is not a new idea, but the paradigm itself is pretty interesting. So this one, we ask participants to learn a new skill. In this case, we ask people to learn to read Chinese characters. And what we do is we ask them to study these characters every day for several days. And then after a while, they start to make associations and they can actually identify the Chinese characters. So we like this because it's practical. It's like a new skill that you might enjoy. There's other ideas here, which I can go into, like learning constellations, bird songs, art and artists, musical compositions, but we chose Chinese characters as a starting place. This is how the task works. So they hear an audio or they see the text that just says noodle. Then they're shown a Chinese character. And then they're asked to press D if they think the character matches the word they heard, or press K if they don't think it matches, or sorry, K if it matches and D if it doesn't match. And what's critical here is that we don't provide any feedback. So for example, they may hear noodle, and they may see this, which I think is the symbol for father, which is an incorrect match, and they just have to guess, is it a match or not? But over time, the thing about this test is that you see the correct matches more often. That's the critical piece here. So just like you learned a language, you didn't have someone correcting you every single time, or when you heard your parents model, like this is a ball, this is a box, this is a foot, you just heard those things and they went together. And then over time, you heard them so often together that you begin to make associations and you learn it. But on day one, they see the correct matches twice as often as the incorrect matches, which is pretty much indistinguishable for people. But by day 6, they've seen the correct matches 12 times more often. So after a few days, they get more confident, learning starts to take place. But in the early stages of dementia, we think that learning rate is much slower. And I'll show you some data to suggest that that is the case. So the test in this test is the learning rate. So we're looking at learning of new information. So we have one paper that we just published on this. This is from ABLE, which is an Australian study of biomarkers and lifestyle. And we took a small sample, 20 people with amyloid in their brain, but cognitively normal, and 30 older adults with no amyloid in their brain, plus a younger control group. And we found huge effects. Like I've never seen an effect size this large in the preclinical AD world. So we've shown that reduced learning happened as a result of preclinical Alzheimer's disease. And importantly, when we gave them standard cognitive tests, like a list learning test or a paragraph memory test, there was no difference between the preclinical Alzheimer's disease group and the normal older adult group. So this is a huge finding, and I'm really excited about this paper. And subsequently, this group has put out another paper in neurology, I believe in the last month, that expands upon this data with a few more subjects. So we wanted to make a version of this for the smartphone application that we work with. And we're piloting what we call a burst version, where we repeat the measures in a short period of time. We want to tune this paradigm very rapidly with our, my lab has an iterative development pipeline where we use online beta testers. And right now we're getting close to, by the end of this project, we'll have well over 1,000 people that have tested this. Our current design is to reduce the footprint of this, because the original task asked participants to learn 50 characters that took about 25 minutes a day over 6 days. So we've reduced that down to 8 characters, where they learn in 6 sessions per day for either 1 or 2 days, and each session takes about 2 minutes. So they see a character and a word, and they have to decide if it matches for about 2 minutes in a row. Then the next time they come back, they do the same thing 6 times in 1 day, or 6 times on day 1 and day 2. So the total assessment time, we've gotten it down from 2.5 hours in the original task down to about 24 minutes total. So this is what it looks like. In this case, there's no audio because it's on a smartphone. So they just see the text, then they see the character. In this case, it matches and they have to say yes. And the same with a non-match, and they would say no for this one after they've learned it. So here's what the data look like. So we did an important manipulation here. So on the top, you'll see where we actually showed people the same set of 8 characters on day 1, and again, the same set on day 2. And then on the bottom, you'll see people, we show them the same set of, we showed characters on day 1, and then a new set of 8 characters on day 2, because we wanted to see if there was some carryover effect of the task itself versus the characters itself. And the upshot of that is we found no effect of the task itself. People basically restarted on day 2 on the bottom. So we've essentially taken people from a 50% at start, when they're just kind of randomly guessing, up to about 83% by the end of day 2 in just 24 minutes, which mirrors exactly what they showed in the what we showed in the publication that Janelle Baker, a graduate student, published. And just this is the same data shown in a different way. In the red box is the accuracy rate over the days. So if you look at the top line, that's the same set, and that started at about 50% in the first block to about 72.4%. And then by day 2, they got up to close to 84%. And if we showed on day 2 a new set of characters, they basically reset all the way down to 0 and got a very similar learning rate. So I'm very, very pleased with the results of these studies, where we've essentially taken 2.5 hours of data collection and reduced it down to about 24 minutes and got almost exactly the same results. So I'm really pleased with this. Another test that we're working on, and if someone has questions, please interrupt at anytime, is called accelerated long-term forgetting. And this takes advantage of the fact that we usually do a really short recall period in traditional cognitive testing, but we wanted to extend that out to like 7 days, which we call long-term forgetting. And then we have a 30-day version where we actually carry it out to 30 days. And this is based off of some work that some colleagues have done in the DIAN study, where they showed people who have carrying a pathogenic mutation for Alzheimer's disease but cognitively normal, they asked them to do a paragraph recall test, and then 7 days later they asked them to recall it again. And although there were no differences at 30 minutes, after 7 days they started to see some separation in the carriers versus non-carriers, which suggests that long-term storage is impacted by mutation status. Well, I'm sorry, I'm not sure what's going on. There we go. So we've developed a web-based portal to do this in the DIAN study. We're not yet doing this in the Alzheimer's Disease Center, where we give people a couple of different paradigms. We've tried maybe 5 or 6 different tests. We have a list learning test that works really nicely on the web, where people are shown words and they're asked to type in the words as quickly as they can. And yes, we've taken all kinds of protections against cheating, like you can't copy and paste. Of course, we can't prevent people from writing them down, but there are time limits, and so if they tried to do that, it wouldn't be a very effective strategy. We've done as much as we can to protect against cheating. Then we also have a card memory task, which is based off of the childhood game, which I think is called Memory, at least in the United States, where you put out a bunch of cards and you have to flip them over and find the pairs. And both of these work pretty well. So they get 3 tries to find the pairs, and then after 6 days, we ask them to do it again. And so we have the really long delay 6 days later, and then in another version we have the really F long delay, which is what our internal language for it, which is 30 days later. We asked them to do the same tests, and this is a super small sample of just 11 mutation carriers from DIAN, but we were able to prove that the task is working really well. So after 6 days, there's a huge loss in word list recall, and a huge increase in the number of flips that people had to make to find matches. But we don't have any group by mutation status comparisons just yet. We're still collecting this data. But I just wanted to show you the type of task that we're working on. And what time is it? Okay, I just have a few more minutes, so I can briefly cover adherence, or if people want to ask some questions, I'm very happy to get into that. So if anyone has some, please post them in the chat. I'll pull it up so I can see it, but I'll start talking about adherence in the meantime. Is someone there? Okay. So adherence, retention, engagement, follow-up, whatever you want to call it. This is a huge issue in remote studies that I think doesn't get enough attention from really anyone. So I went and looked in the literature a few months ago to see what kind of retention rates people were getting, because we weren't getting very good ones with our web-based assessments and also our smartphone-based assessments. And I found that others really had a similar experience. And look at these attrition rates. The Empower app, which was touted as a huge crowdsourced effort in the Parkinson's disease field, it's an amazing app. It's beautiful. They had 86% attrition at 6 months. They had several 100,000 people download their application. Only a small percentage of people actually consented for the study, and of those that consented, 86% of them dropped out. And similar results for other studies. The iVitality app had about a 40% attrition, but this was actually part of a center-wide study. So that's still pretty darn high. Even though these people were compliant with coming into the study, they dropped out of the online study that accompanied their clinic visits. And then the Brain Health Registry is a very popular one in the Alzheimer's disease world, which has several thousand participants. They have 74% attrition at 42 months. And in DIAN, our ARC app, which led to me making these slides, was we had about 55% completion, 20% attrition. So I'm just as guilty of not taking adherence seriously as everybody else. But this is a big thing if you want to go remote with your studies. The less interaction you have with participants, the less they will engage with your technology. It is not the kind of thing that you can set and forget. You really have to keep engaged with them if you want them to adhere. A really interesting study came out this year in Nature Digital Medicine from a developer in Seattle who is involved in many different studies called Sage Bionetworks. This is interesting. When they crowdsourced applications, they found that the median engagement time was 5.5 days, of which 2 days included in-app tasks. And these are longitudinal studies, so these are not one-hit studies. These are expecting to follow people with these studies, and they found a median engagement time of 5.5 days, which I think is pretty abysmal. The median retention time was between 2 and 12 days, but retention factors were associated with older age. So older adults had the highest retention rate, which is again what I see in my studies. If the app is specific to a clinical condition like multiple sclerosis, Alzheimer's, hearing loss, whatever, they were much more likely to be adherent. And if they were referred by a clinician, they were more likely to be adherent. And if it were involved in a randomized controlled trial, it was a 26-day median adherence. So if you look at a big plot of adherence, you can kind of see right away which one is the randomized controlled trial. If you can see my mouse, it's the Brighton study here. This one was and the other ones had huge dropout like right away. So what's going on? We did a focus group to try and figure out how to make this better for people. It was pretty fun, actually. We got people who were ages 60 to 84, 10 older adults, and we got them to sit with an app and a microphone and sort of identify the pain points for us. And we got some pretty interesting results. These are just some quotes that we pulled from those recordings that I thought were pretty funny. The tests are really hard and make me feel stupid. This is a big one, especially with older adults. They don't like being being felt like they're not in control or that they're breaking the app. This is a huge thing with older adults. They feel like they're breaking it. You know, they can't use Zoom. I broke it, you know, and they get very technophobic. So you really have to assuage those concerns carefully. Another quote that we saw was that the notifications like for our app were coming and they have no idea of when they're done. And this is a big thing for remote testing when you don't have a supervisor sitting there with them. They want to know where they are in the study. They want some sort of sense of agency. Like, when is this over? When is it complete? You know, so a little status bar or a task bar that says you have one more to go. You have 5 minutes remaining. Those things do wonders for people. This is what I was alluding to before. People just are very afraid that they're breaking the technology. Older adults especially do not like sudden changes in the app. Like if the app, like, they need transitions and guidance that things are going to change, like sudden changes, things dropping off the screen and appearing on the screen. We found that that was very off-putting for a lot of older adults. And then they felt like they had no control over the notifications on our app. These are other things. And then this was my absolute favorite quote, was that this was made by young people and it shows. So we took this all to heart. It was a very, very hard pill to swallow, but we did a massive redesign of our application, which I'm just going to cover really quickly. One thing we didn't think about was providing people with a way to go back and explain the task really well, and also make it really obvious using features on smartphones like vibrations or ergonomic sense of touch, you know, that would help with older adults. So if they don't understand, it actually gives them a little hint and it walks them through how to do these things. And we also spent some time doing these onboard tutorials, which we'd never done before because we just didn't take adherence seriously from the beginning, which was a huge mistake. We also give people some sense of where they are in the study. We give them badges, confetti. We tell them, yes, you've completed this many, you have one more to go. Here's where you are in the study. You've got this much more till you're finished. You finished this this cycle, and we've made it very explicit for them where they are. We also did a lot of work on the back end. We created a dashboard so that we could see where everybody is at any one time. And if there are anybody who's being non-adherent or non-compliant, they would pop up on our alert list, and then we can contact them to see what's going on. And then another thing we did was reimbursement. I'm not going to get into gamification because we're running out of time, but we actually pay people now. And I don't know if this is really the answer or not, but it has improved adherence. So people get some sort of sense of accomplishment out of this. And many of our participants are so wonderful, they actually donate the money back to us or refuse to take it, but they still like to see, you know, this thing. So we have bonuses where if they complete multiple tests per day, they get an additional bonus. If they complete a certain number of the week, they get an additional bonus. They can earn up to $30 per visit. This adds to your cost though. You know, we have 400 or 500 people that are going to be using this app. So this adds a lot of money to the study budget. Not to mention buying smartphones, but that's another story. We also are using some nudge tactics. These are social psychology cues where we actually make people verbally commit, which is a huge thing for a lot of people. And then we also vary the messaging that we use to remind people, where it might be like an altruistic message, which might be more effective for people. It might be a monetary incentive that says, you know, there's another chance to earn money. And then there's just completion rates, which was actually very interesting. We heard from several of our participants that they just like to know that they did all 20 tests or all 25 tests. You know, that was like very much an incentive in and of itself. So it's very interesting. So I'm going to skip all of this, and I just going to get to my acknowledgement slide. I really want to thank Andy Aschenbrenner, who is a faculty member in neurology with us now, my former postdoc, who's been so essential to this. And I really want to acknowledge my funding sources, and of course the participants and families from the night ADRC. And just before I conclude, I'm happy to take any questions, and I do want to shamelessly plug that I'm desperately looking for postdoctoral fellows. I have slots for 2, so if anybody is interested, please share the word. We have a lot of fun in my lab, and if you want to help create new cognitive tests and create new technology, please have people contact me. So I'm happy to take any questions. What is wrong with this?
Thank you so much. If anybody does have questions, feel free to unmute yourself and you can ask. It doesn't look like anybody typed anything in the chat.
Yeah. I think we're over time too, so.
Yeah. Alrighty, well, if you think of something that you, were unable to ask, you can contact Dr. Hassenstab directly. His email address is here.